Well, hello, everybody, and good afternoon or good morning, depending on where you are in the country. My name is Garrett Schmidt, and I'm the CEO and managing editor of VBC Exhibit Hall. I'd like to welcome you all to today's live webinar hosted by Milliman MedInsight. And this one is called Optimizing Outcomes, Leveraging Analytics for Provider Performance in Value-Based Care. We've got a lot of material to cover today, so we're going to get right to it. But a couple items of note before we get started. Everyone is joined today in listen-only mode, so this is a traditional webinar format. You don't need to worry about turning off your camera or your microphone. We can't see you or hear you. However, we will want to hear from you, and so we're going to have a time for some Q&A towards the end of the session today. And if you have a question for any of our speakers, go ahead and drop that into your control module. There's a place as an attendee that you have specifically for questions. We're going to get to as many of those as we can. Again, we've got a lot of material to cover. If we don't get to those or to your question, don't worry though, someone will reach out to make sure your question gets answered. So even if we're wrapping up at the last second, go ahead and ask that question. Finally, today's session is being recorded. So what's going to happen is when we conclude about, let's say an hour or so after the presentation wraps up, you will receive an email, and that will have a link to the recording as well as to the slide deck. And that way you can use that to reference later on and share with colleagues and friends, and we hope that you do so. So without further ado, wanted to briefly introduce our speakers today, and then I will turn it over to them. We have with us, in no particular order, Ms. Francesca Hammerstrom, and she is the General Manager of Value-Based Care with Milliman MedInsight. Then we have Dr. Christopher Kadama, and he is the Chief Medical Officer with Milliman MedInsight. We have Ms. Sam Lewis, Director of Healthcare Business Intelligence and Population Health Analytics with Genesys PHO, and Angie Williamson, and she is an Analyst, Healthcare Business Intelligence and Population Health Analytics, also with Genesys PHO. So welcome to you all. I'll turn it over to you at this time.
Thank you. Thank you so much. It is a beautiful afternoon here on the East Coast where I am, so I will say good afternoon. And thank you so much for joining us. We're really excited to be here with you today. I did want to start by just saying a few more words about the folks that we have on the line, because I am so thrilled to be joined by Sam Lewis and Angie Williamson from Genesys PHO. I've had the pleasure of working with the team at Genesys for the last few years, and I am just always so impressed. These are folks who know their data inside and out, and the reporting that they create for their organization is always thoughtful and actionable and keeps the end user in mind to make sure it's useful. So thrilled to have them here today on the topic of provider reporting and creating engaging, useful data for clinicians. I am also very pleased to introduce Dr. Christopher Kadama. He is Milliman MedInsight's new Chief Medical Officer. And prior to joining us here at MedInsight, Dr. Kadama served as the founding president and CEO of MBright, establishing a truly cutting-edge clinically integrated network, and as an executive leader at Multicare Health System. In the very short time that he's been here with us at MedInsight, I have learned so much from him, and I'm very excited to bring his expertise onto this webinar today. So that is a little bit about us, but before we dive in, we'd love to learn a little bit more about you, who's on the line today. So we wanted to start with just 2 poll questions. You should be seeing the first on your screen now. We would love to know what kind of organization that you're joining us from. There are so many different players involved in value-based care. Are you coming from a health plan, an ACO, more of a classical fee-for-service provider organization? Are you with a government entity or something else? And if you're from a different kind of organization, we would love to know more in the chat about where you are joining us from and what kind of organization you are with.
Okay,
So
you should see, yeah, you should see this up on your screen now, and we realize that this you might be several of these things. So we've made it a question that you can add, you can say, you can choose all that apply here. And this is anonymous, by the way. These are just for fun. We're going to show the results here to you shortly, so you can kind of get an idea also who's with us, and it may sort of guide the conversation today as well for our speakers. So I think most of the results have come in at this point. So I'm going to give it about another 5 long seconds here, and then I'll show you all the results. So close it down in 5, 4, 3, 2, and 1. There's always a couple that come in right there at the end. Okay. Francesca and Dr. Chris and the Genesys folks, are you able to see the results here on the screen?
I do. I do. Yes. Thank you. And thank you all for voting and providing us this information. I'm seeing lots of ACOs online, which is exactly who we are working with a lot of the time. Also, health plans, lots of provider group and healthcare systems, and some others. So fascinated to see who else is joining us today. But it does seem like we are among friends. So thank you for that. Second question is what is your role within the organization? Are you with data analytics or IT? Do you work with providers directly as a provider liaison or network manager? Are you a provider or clinician yourself from the finance team, or again, another bucket? And we would love to know more in the chat about who is joining us today.
Wonderful. And again, the responses are rolling in here. So choose one that best applies. And Francesca, I may have you read out the actual percentage results at the end in case anyone's calling in and they can't see it. And that way they'll get an idea as well. But looks like most of the results have come in here. We'll close it down in about 10 seconds. But again, if we have not listed your title on here or your role in the organization, or even if you're just joining us out of curiosity, which is fine, we're curious if you put in the chat what your role is. That's helpful for us to know as well. And all right, I'm going to go ahead and close it down and share the results. All right, Francesca, are you able to see these?
Yes, I sure can. So 47%, almost half of folks are data analytics and IT. So certainly some like-minded individuals. 13% provider liaison or network manager. I can't wait to hear questions coming from that contingent. 11% clinical, medical director, care manager, et cetera. So again, would love to hear thoughts from that group. And then 29% other. So I will be very interested to see in the chat what other roles are here, and maybe we can add some more options next time. So thank you for sharing more about you. That is really helpful in thinking about kind of how we frame the next 40 or so, 50 or so minutes. Here's the agenda for that time. So first, Dr. Kodama is going to share some thoughts and guiding principles about sharing data with providers in a value-based care context. Then Sam and Angie will share more about their journey and experience in creating meaningful reporting for providers, including how they've structured their team, the data and tools that they're using, how their dashboards have evolved over time, and how those reports have been received. And we'll wrap up with a very quick summary of some of the lessons learned, and we'll leave plenty of time at the end for Q&A. So we can dig in, and I will turn it over to Dr. Kodama.
Thank you, everybody, and thank you, Francesca, for getting us kicked off here with Garrett. I'm thrilled to be able to join you today and have had so much fun. I was talking with the team presenting today about how much I love to learn from folks. And judging by the responses to the poll questions, as suspected, we have a pretty diverse audience of stakeholders and different perspectives. And we're in good company here today. I suspect we all experience some of the common challenges associated with shifting to value-based care and promoting this in our various environments. And there's, for our ACO colleagues on the line, I always used to say, if you've met one ACO, you've met one ACO. And yet there are some common themes, I think, that apply for all of us, regardless of where we're coming from to this conversation about value-based care. And I wanted to spend a moment just walking through these so that you have these in the back of your mind as you're listening from what Sam and Angie have to share with you today. And these can apply to any aspect of what you do in your work. Today, our context, as noted, is really focused on engaging providers through the leveraging data and transforming that into actionable information. And so these are the three things that I have either thought about myself in launching a couple of ACOs here in the Pacific Northwest, as well as having the opportunity to collaborate and learn from colleagues around the country, some of whom may very well be on this call today. And I thank you for that. And those are impact, sustainability, and scale. So when I think about a strategic decision or an investment, and particularly in this provider engagement space of leveraging data, The first question really is, will the approach that I'm taking, the investment in tools, the process, et cetera, have a desired impact? In other words, how will this engage providers whose decisions are and behaviors at the point of care is really what's going to drive the health of populations, which is what this is value-based care is really meant to be all about. The second guiding principle is that I like to test against is, how will this help us improve population health in a way that's pragmatic and financially sustainable? Because if it's exclusively mission oriented, but you don't have the financial sustainability to support the tools, infrastructure, and strategies to be most impactful, that will be a problem longer term in terms of being able to serve your mission of continuing to improve population health for the communities you serve. And the third guiding principle is scale. How do these decisions, investments, strategies, and approaches expand our efforts across a broader swath of populations? So how do we scale that impact in a way that is not just so tightly fitted to a particular use case that it cannot be applied in other areas? On the next slide, you're going to see a list on the left-hand side of some of the more common challenges in optimizing health outcomes. It's by no means exhaustive, as we all know. I'm going to go into these in a little bit more detail in just a moment. What I'd encourage people to also think about as you listen to this presentation is the graphic on the right, which keys off of the old Indian fable of multiple people touching different parts of an elephant. And in many ways, as we try to solve for better population health, that is the elephant. And you've got a lot of different stakeholders that you saw and heard from Francesca during the polling questions, and all of those perspectives, all of those experiences, and the information that you touch, the imperatives and priorities that you have are important to the conversation. Part of this question around impact, sustainability, and scale is, how do you bring those distinct perspectives and stakeholder groups together under a shared set of priorities that are going to have the greatest impact in getting after the population health outcomes that you desire? So as we look at the next slide and break out a little bit more of these challenges, it's not all doom and gloom. There is hope, as we know, and many of you have tested some of these countermeasures or found additional ones that are equally, if not more effective. I'd like to walk through each of these, highlighting the countermeasures so that you can be paying attention to some of these countermeasures and what you hear from Sam and Angie in just a moment. The first is, I know I have felt overwhelmed at times about where do I begin. There's so much more data and information available than used to be the case, and this continues to grow daily. And one of the things that can be very helpful is to pause, take a deep breath, and the other is to deconstruct the challenges ahead of you into manageable parts. How do you leverage the data to identify where your key priorities are? Some people like to use the Pareto analysis of the 20% of houses on fire that will have 80% of the impact on the overall neighborhood. And that's one way to kind of think about getting past overwhelming. And hopefully you'll take away some very concrete examples of how Angie and Sam have led this at Genesys PHO with their colleagues. The second is the sheer complexity. So lots of different stakeholders amplified by a lot of data and information, amplified by a lot of different potential priorities. And here it sounds more simple on this slide than it actually is. I appreciate that. But creating clarity wherever you can. Shutting down sort of the myth or the anecdotal or the purely subjective by bringing more objective data and information in the conversation is one way that you can enhance clarity for people. Honoring and respecting diverse perspectives. Just because somebody has a different opinion or is coming at the problem differently from you doesn't mean that it isn't a valid consideration in your overall planning. And one of the ways to draw diverse perspectives together revolves around fostering a shared sense of vision. What is it you aspire to become together? And creating that mutual understanding, which leads us to the next challenge around, there are a lot of different healthcare dialects over time. And I had the benefit of attending a Healthcare Futures think tank conference many years ago, at which they coined the term multifluency. This notion that in complex ecosystems like healthcare, these different stakeholders, the different people touching different parts of the elephant, may be using different terms or thinking about different concepts than you may be as you touch a different part of the elephant. And so if you think about this, there may be a dialect in your organization for the finance analysts and the CFO and financial managers. There may be a different dialect in terms of what the clinicians are using, similar for operations and other clinical support teams. So how do you begin to develop shared fluency? Because a lot of times the sense of overwhelm, complexity, and managing diverse perspectives is the result of people using the same terms to mean different things or using different terms to mean the same thing. And so pausing, asking yourself that question if that is contributing to any misunderstanding or lack of alignment across your enterprise can be a very valuable step. This keys into distinct learning styles and audiences. There are visual learners, audio learners, etc. People process information differently. So how do you curate this multitude of data points into something that is curated appropriately for your different audiences in a way that they can ingest, internalize, and act upon? One of the other challenges we experience in terms of engaging providers and others in improving health outcomes is the lack of timely insights. This is a very common one. I remember standing up networks with more seasoned physicians and physician practices who'd lived through the 90s, where they were being held accountable to outcomes for which they had very little intelligence during a performance year to do anything about. So now we have access to sources of clinical data. We have the ability to process claims data in ways that can enhance and enable rapid cycle feedback loops, including the use of tools like timely performance dashboards, which Angie and Sam are going to talk a little bit more about. And then there's ambiguous linkages between actions and outcomes, or cause and effect. So being thoughtful about marrying leading and lagging indicators. Some people use this as in process or refer to these as in process versus outcomes indicators. There's other terms around this. And the point here is you want to be able to understand what a change in behavior does or does not do in terms of achieving the desired outcome and impact. And also focusing in on those priorities, leading and lagging indicators as a reflection of those that you can control and influence. There's no better way to disengage physicians than to put them in a self-defeating scenario. And so it's really critical that you start where they see the line of, have that line of sight. Engagement, whether that's with physicians or others in the organization. Many of us are drawn to healthcare because of a scientific point of view or aptitude. So having confidence in the data, building trust in the information that you are receiving is a journey that needs to be very intentional. And finally, the misalignment of incentives presents potentially a lot of challenges here. And in this, I think it's very natural to want to gravitate to financial incentives, which is an important component of the puzzle. But you may identify hotspots through thoughtful data analytics where you can get creative in potentially less direct financial incentives. So I'll give you a quick example here of a friend and former colleague who worked in a provider organization where it was very important to the physicians to be able to grow their panel size. So what that organization did was they set certain quality and cost and utilization measures that had to be hit at a specific threshold in order to trigger the opportunity for that physician's panel to be expanded. And it was really quite elegant in my mind in the sense that what they were making it abundantly clear is if we're going to scale your practice, we want that scale to have a positive impact on the health and outcomes of these additional lives that you're going to be funneling through your panel. So in summary, I'd encourage you to think about the three guiding principles as we go through this presentation with Sam and Angie of impact, sustainability, and scale. How are the things that they're describing hitting those notes? And then paying attention to concrete examples of how they've deconstructed the overwhelming into priorities, how they've created clarity, vision, mutual understanding, and enhanced multi-fluency for different audiences, and curated information in a way that can be digested and acted upon in an intentional way. And also be listening for concrete examples of how they have enabled rapid cycle feedback, how they've tied cause and effect, focused on control and influence, as well as built trust and getting creative about realigning incentives. So with no further ado, I'm very pleased and excited to hand the stage over to Sam and Angie so you can hear from them. Thank you.
Thank you, Dr. Kanama. Angie and I are both happy to be here this afternoon and to talk about who we are at PHO. And if you can move on to the next slide. The most important thing you need to know about us is that we are a practice management organization for about 100 plus primary care providers and around 300 specialists. And for our population, 76.3% are in downside risk contracts or value-based care. So analytics here are important. Moving on. This is a lesson we learned from our boss before she moved on. Successful teams don't happen by accident. They are made, not born. Certainly true about analytics. This is basically our origin story that we're going to tell you so that you understand how our team was formed and how we started doing the work of value-based care. In 2012, the ACO Pioneer model was available and Genesys PHO jumped in. By 2015, our CEO understood that there was no way we could be successful without analytics if we were going to enter downside risk. So he started partnering with Milliman. But within a couple of years, he understood that there is a difference between analytics and IS. And at that point brought in our Vice President, Michelle, who was on the health plan side working in risk contracting. And the first hire for Michelle was myself as a data scientist. Within 6 months, we added a data analyst and a data architect because we obviously knew we had a lot of work to do and we needed someone to clean up our data. Finally, in the last few years, we've added an HCC risk coding specialist who pretty much addresses some of the holes that we found in the data along the way. Moving on. As analysts, and I noticed there were a lot of people from data analytics in this call, you should know nothing is ever created as a final version. Everything that we do is a process and is open to change. So when Michelle and I first sat down and formed this team, I take credit. It was all her. But when our team started to form, the first thing that we did was make a list of all the key performance measures or indicators that would tell us, have we succeeded? Are we succeeding in our risk contracts? And by doing that, we came up with a whole list of data that was necessary. As we developed that list, we also developed the elements that we needed that were not available to us at the time, what we had on hand, what would help us see success across certain programs and projects. And we also looked at the current trends to see what needed to be measured and what needed to be improved.
So next you get to build, no?
Oh, can you go back?
Go
Sorry.
back, we weren't doing that.
We're still in the middle, yeah.
Yep. So next what you need to do is you need to build the report. And building the report is really where you're going to start telling the data story. As analysts, we're not just analysts, we are storytellers. We need to brand it correctly so that everybody knows that it's coming from our department. Build in a color scheme so that any report that comes across from our team is recognizable as something from our team. Make sure that your data consistency is there because they're not going to have that data confidence that they need in order to trust the reports that you're bringing them. We need, as data analysts, to bring the data in and make it actionable information for our audience.
So once the report is built and we are ready, we learned very early on that just because we can build it doesn't mean that our audience can understand it. And in order to reach the provider audience, we have to actually present it to our provider audience. So when we have something built and ready to go, we take it to our medical directors and they go through it. And At that point, we take any feedback or constructive criticism they have. If they don't think that it's something that they can move the dial on, then we will make changes to the report, come back, present it again, until we finally believe between the clinical side and the analytics side that we have a final product that has value. Once we've delivered the report to our appropriate audience, we take more feedback and constructive criticism from everyone receiving the report. And we make any changes to the report that are necessary. You're going to hear the word change over and over again. We're analytics. So the industry changes, the market changes, healthcare changes, diseases change. And along the way, if you want to know if your report is having impact, you have to measure for possible impact. I think that was the one piece that I saw missing over and over again on the health plan side and even on the provider side. Whether or not you can change an element that you're measuring should tell you whether or not it's worth it to certain audiences to see on a regular basis. Now we can move on to the next slide. Oh, this is me. So we have a very small team. Analytics here are deployed with a purpose, meaning we focus almost entirely on contract performance analytics, but in our world that also ties to population health. If we're doing well on a contract, that means we have more incentive money. If we have more incentive money, then we have more money for our programs for our patients. So it helps to be focused and passionate about the work that you do if you want to have impact on the community you live in. Our reports are organization and position-wide, so that's the split. We look at shared savings calculations. We look at performance versus contract benchmarks. We look at financial projections. We do network leakage. We do performance and incentive reporting, meaning we tie the incentives and bonuses for our providers to the performance needed to win in our risk contracts. By doing that, it makes it something that they want to pay attention to and that they want to understand.
On our physician side, we deliver care management and social determinants analytics, utilization reporting, quality management, attribution and panel management. All of those things tie into their incentives, so they want to know where they're actually at in meeting those goals. We also do risk adjustment and coding analytics that go out to our physicians to help them with their billing and practice management. You can move on to the next slide. The cadence of reporting is absolutely important. You never want to deliver anything that monthly that is not going to show enough movement to be actionable. So our monthly reports are our finance dashboards, our utilization reports, quality reporting, PCP incentive structure. Those things are actionable every month. Quarterly, we deliver our continuity of care, practice management, shared savings projections, because you're not going to see enough movement in the data from month to month, so those are reported on quarterly. And annually, we give them panel management.
Angie's really great about making sure that our providers actually understand all the terminology used in our report, either by adding a data dictionary, which she uses terms to know, so that they don't have to ask back and forth when they're first reviewing a report. But when I first started doing the work of director, I probably had 60 to 80 deep dives a month, just myself. Because when you present a report with trends that have changed, you need to be prepared, or your team needs to be prepared to answer those questions. Why has the trend changed? What detail can you offer them to point them in the right direction if they want to have impact? But thankfully, Francesca came along with value-based care insights, and we were able to save about 60 to 80 hours a month just from not having to run all the separate reports in order to get to the deep dive information. And BBCI has been a huge benefit for us. You want to show the first slide? This is just snippets of it because I insisted that we include it because it saved my team a lot of time. And when you have a small team, how you spend your time matters. It gives a summary of executive summary. You can filter it on insurance company, line of business. If you only want to look at your Medicare patients, it gives you that. But it gives you all the basic information you want to present to your executive board at the highest level, as well as the top 5 cost saving opportunities. And because it's a beautifully built report, whenever you would show this information to a board, they're going to ask, what can you do about A, B, C, D, and E? And the BBCI tool is built so that when you click into each level, you're going to get more and more information. This identifies inpatient medical, big surprise, right? As highest cost of care and the biggest trending change. As soon as you click on it, you're going to see exactly where you're at now compared to where you were at last year. And if it's a problem over time, you're going to see that really quickly. And it shows you if the basic problem is, are your patients going out of network? You're going to see that in a flash. If you want more detail, which I have a board and nurses, they're always going to want more detail. You can get detail by the DRG. You can get detail by facility. You can see where your patients have gone, how they handled their discharge, whether or not they were readmitted, all in less than 10 minutes. It's an amazing tool for me, and my boss is probably just finding out now how quickly I can get to answers for her. That used to take me days, so it's a benefit. If you can move on just one more slide. Yeah, and if you see as you go through your inpatient that your discharges are coming back, you can actually look at the SNP information to see where they were discharged to, how long they were in the SNP before they returned to the hospital. The level of detail that's quickly available is just a beautiful thing. Okay, so what does great collaboration look like? With analysts, there's often a wall between, especially when I worked on the health plan side, 5,000 employees. Your job is very small. The amount of information you get is even smaller. And I don't think, even as a senior analyst, anyone ever sat me down and explained, these are the top 3 things we want to work on this year. Unfortunately, if your analysts don't understand what your goals are, they will not understand what type of reporting to deliver. When you work on the provider side, it's a little smaller. We don't have the number of employees, so there's less of a wall. I would even suggest taking the time to go to your analysts before you set your goals and ask them, are these things reasonable? And if they are, how can we get there? Take the time to review insight briefs instead of raw data. Don't send the doctors tables of information. Do not expect them to be able to assess what you want them to see. Instead of doing that, actually give them the summary statements. It allows for a deeper level of information that they need in order to understand why you're even taking the time to show them this report. Even better, I work with a nurse and providers, and once a month we have a standing meeting that helps me to sit down and make sure that they have correctly interpreted the reports that I've provided them, rather than just emailing them and hoping for the best. But yeah, it doesn't always work out well when we do that. So it's even better when they have a chance one-on-one to ask the questions they need to ask about the data. We have Angie. Every team needs an Angie. She is our bridge and our interpreter. I don't understand clinical. Most of our clinicians do not understand analytics. They think what we do is magic. We have wands. It's great. I think what they do is magic. They have wands. That's great. But Angie sits between us and makes sure that we understand each other.
You also want to encourage your analysts to flag those unexpected outliers. We had a patient call our compliance hotline and complain about an EOB that she had received in the mail. that had charged her for some DME items that she didn't actually use. Everybody remembers a couple years ago when we had the big DME fraud that hit CMS. So we actually were tasked with trying to find out if we had been a part of this. And we actually found 7 different companies that were fraudulently charging our patients for DME. And if we hadn't been encouraged to look for, this outside thing, DME isn't something that we can control. It's very small in the cost of care. And so we never even thought to look for it. And we called it our Sherlock and Watson project because we got to put on our data detective hats and become data detectives. So if you flag those unexpected things, they're not quite such a shock when you actually find them. You can go to the next slide, Francesca. So our reporting and analytics, how did we know where to start? You have to know which audience is going to be receiving these reports, because if it's not important to you, you're not going to read it, and we don't want to waste your time. So our finance dashboard, it goes to our executives and hospital partners because our fiscal performance is important to them. Utilization reports, they go to everyone, our executives, the physicians, the hospital partners. How they are received, though, could be different. They are not reported to each of those levels the same way. Continuity of care, leakage in inpatient, outpatient, ambulatory, surgical centers, that goes to our executives and our hospital partner. Our hospital partner loves that report. Population risk stratification goes to our physicians, as does the practice management, so that they can see exactly how their practice is performing against their peers.
And the risk strat obviously makes it easier for our providers who have thousands of patients to quickly hone in, especially with the help of a care manager, on the patients that need care who haven't been treated as of yet. I think it's one of the most important things that we do.
Mm-hmm. Next slide, Francesca. Oh, how our reports have changed over time. This is what our finance dashboard looked like to begin with. I call this the wall of numbers. It is very intimidating. It's overwhelming. It's complex. I don't know if it had any impact, because you look at it and you think, where do I even begin? You are not going to be engaged with this. It's not very intuitive. So it kind of has melded from this to what you see on the next slide, which is concise, well-organized, color-coded. It's inviting. It makes you want to look at the data. Things are grouped together, so your membership is on one page, and our hospital readmissions and our PMPM, our inpatient per 1,000 rates are all on the same page. We've recently added back risk scores, our average risk scores, because our audience didn't understand risk scores at first, and now we've been working with them and they're starting to understand it, so we've added it back to this report. And it's just really a great tool to help keep them engaged with the reporting.
Provider education is going to be important all the way along the way.
Absolutely.
Providers don't do what we do, and we don't do what they do. I would not want to have to do heart surgery. You do not want them to have to understand predictive analytics. Use the terms that they are comfortable with and make sure that you're speaking the same language. You can go to the next slide. How you deliver information is just as important as what you deliver. Our data architect, Jenny, spent 4 to 6 months working on a report that had been requested. They wanted all the information that was going into the util report so they could quickly flip from each measure and look at the top 25 performers and the bottom 25 performers. Unfortunately, after all that time and work, we discovered that they don't want to use Power BI ever. So we scrapped it and moved on.
You need to create a safe space, though, for your end users to be able to come back to you and tell you that they don't want to learn a new software product, or that something isn't working for you, because you're going to continue to produce these reports or to update those dashboards in a software program that they're never going to use because they don't feel comfortable telling you that they can't use it or they don't want to learn.
So it's important to make sure that they feel comfortable working with you and giving you honest feedback. That feedback loop is absolutely vital. Moving on. Oh, the lessons we learn. So I know I've probably said it quite a bit, but there is no finished product in analytics. Everything changes, needs change, trends change. Once you've mastered something and you're doing really well in it, you move on. You might track it as analytics, but you may not need to report on it, especially at the provider level. Our practice management report has been refined 7 times in the last year. We started out with a 9-page report, and
We're down to 6.
after the first version, we were down to 6. I think we're now down to 5.
Mm-hmm.
But it's important to understand that we consider our experts part of our team. So their feedback helps to build a better report.
And don't forget that feedback isn't personal, okay? And the report, even as the analyst, it's not my report. It's my audience's report. And if it's not important to them, then I can't take it personally when they ask me to remove it. I thought it was a great idea, but they didn't. And they're ultimately the ones that are going to take that data and make it into an actionable outcome. So we have to remember that feedback is not personal.
And they have knowledge that we don't.
Correct.
It's important to listen as much as it is to talk. The outcomes will be stronger and better. The lessons that we've learned all along has basically been listen more. Know that your audience's time is worth a lot. So if you use too much of it, you have wasted it.
Next slide. So you don't need to be a data expert. You need to be a data navigator. This is for our executives, right? Our executives, they don't need to be a data expert. They just need to be able to navigate the information that we give them into actionable items. So don't expect them to know exactly everything, but educate them enough that they can navigate through those reports and they can tell someone else exactly what they say without you standing in the room.
And for executives, define the outcomes that you want. Let them know where you're trying to get to this year or in the next 5 years. And then at the very least, they can back into the right insights for you without having to pull every single piece of information out of you one email at a time.
Empower your analysts with your goals and your context. If you ask me for a number, I can give you the number, but I don't know what it means. And it really probably isn't the answer that you're looking for because you didn't give me all of the context behind the question. So empower your analysts with the full story so that they can give you the full answer.
Yeah. Remember that the best analytics are the ones that tell a data story. And the story has to be well understood and obvious to your audience. So once a month, review your dashboards. Ask the question, so what? What did you learn from the report?
And if you haven't, maybe it's time to go back to the drawing board.
Exactly.
Fantastic. Thank you, Sam and Angie, for sharing such amazing information. And I will let everybody know that we are wrapping up, just a couple final slides and poll questions, but get your Q&A questions ready. You can enter those into the box at any time. And just before we get into Q&A, I wanted to share a couple of closing thoughts and lessons learned based on all the conversations that I've been able to have with Genesys team and so many of our other Milliman MedInsight clients. The first, and I think we heard a lot about this today from Dr. Kadama and Sam and Angie, there are so many different stakeholders involved in creating reporting that's going to be meaningful and useful and actionable. So getting the right group engaged and involved from the start is an important consideration. I also hear pretty consistently that the metrics that are selected to be shared with clinicians are key, with kind of 3 big criteria. One, the metrics must be related to the value-based care contract. They should drive towards success in the contract itself. Two, they must be impactable by the providers that are receiving the reports. What can the clinicians do to move the needle on the metric? And then three, there must be data readily available to create those measures. That's a key that can often be overlooked. So next, thinking about valuing the provider's time, really considering your audience. The reporting must be, easy to digest, understand, and useful to the folks who are receiving it. And then finally, establishing that feedback loop. This is certainly an instance where no news isn't good news. It's tempting to think that if you put reporting out into the world and hear no complaints, it must be perfectly designed and is being used just as you intended. But in my experience as a data analyst, I found that really the opposite is true, that when you hear feedback and complaints, it actually means that people are engaging in the reporting and trying to use it. And that conversation, the back and forth, is key to creating that feedback loop that's going to improve the reporting and drive engagement over time. So with all that said, 2 closing polls. With all that you've heard today, would love to know, how would you grade your organization? How effectively does your organization share data with clinicians on your value-based care initiatives? And we have just a 1 to 5 scale here.
Right, and you will see this up on your screen. And as before, if you were joining us a little bit later, these are anonymous, but it's just kind of for fun and for you to see where you stack among your colleagues. We're going to show the results here momentarily. And the question is, how effective is your organization at identifying and prioritizing sharing data with clinicians in your organization regarding value-based care initiatives? And I think most of the results are in at this point. Well, they're still coming in, so we'll give it another maybe 5 seconds or so. 4, 3, 2, and 1. All right.
Perfect.
Francesca, are you able to see it?
Yes, I can. So I'm seeing just 4% rating themselves, their own organizations, as very highly effective. So it sounds like generally folks are agreeing there's some room to improvement. 30% thrilled to hear highly effective, 41% at moderately effective, and smaller numbers down below as well. So our second and final poll question, what tools does your organization use to monitor trends and data related to provider reporting? And so here we're thinking about, are you using homegrown tools, things that you've developed within your own organization? Are you using a general analytics platform like a Tableau or Power BI, sort of not healthcare specific, not value-based care specific? Are you relying on your EHR for value-based care reporting? Or finally, do you have a dedicated value-based care platform or other? What haven't I thought of that you are using today?
Okay, and as before, looks like the results are still coming in, so we'll give it another few seconds and then show what you have said. Okay, I think most of the results have come in, so I'm going to go ahead and show the results. There you go, Francesca.
Yeah, so custom internal systems, manual spreadsheets, 71%, so by far and away the most popular answer. EHR, electronic health systems, at 38%. I think our question is too long. It's a little harder to see some of these answers, but sounds like lots of homegrown tools and some good use of the others as well. So thank you for those thoughts. It's wonderful to hear, where everyone is in their provider reporting journey, and we are at the end with our Q&A, so would love to get those questions.
All right, so if you do have a question for any of our speakers, I know we covered a lot of information today, so your head may be spinning around, but that's okay. If you have a question, just throw it in there, and we're going to get to as many as we can. We do have a big audience today, so if we don't get to yours for some reason, don't worry. Someone will reach out to make sure we answer your question. But in no particular order, I'm going to go ahead and start with this one. How have you used analytics insights to close care gaps or improve quality scores in specific value-based contracts?
I assume that question is for Angie and myself.
Sure. Yeah, go ahead and take it. This one wasn't specified, but yeah, go ahead.
On our side, we have specific quality measures that are tied to all of our risk contracts, and we've done kind of a paring down of those so that our physicians are only actually tracking 12 measures per year. And of those 12 measures, it's actually we have quality analysts here, and while they're not a part of our department, they're probably the best at reporting quality anywhere in the building, and they deliver up to the minute EHR data to our providers. So they know as of yesterday how many gaps are open for each and every one of those measures.
Great. All right. Next question here. We'll just keep rolling because again, we've got a bunch of questions. What training or support resources did you provide to help staff and providers adapt to the new platforms or to new analytics platforms, I guess?
Okay. It's a combination of several things. When we first started rolling out the util reports, I believe Michelle and I were both shocked to find out that we had providers who had no idea what any of the terminology meant. This was pre-Angie. And we learned at that point that we had a huge learning curve to get past for both the staff members who were delivering the reports who needed to learn to speak to them, and for the providers who needed both the data dictionary, basic terminology, and a leg to connect the data to what they could impact. So we have a lot of training to do, both for staff and office staff and providers. So they got visuals, they got videos, they were sent live human beings to talk to them, walk them through the reports. Michelle at one point did a roadshow. I don't talk to providers generally unless it's on the phone and unless it's really necessary. Usually I either send our people person or Tanya to field those types of questions, but education is absolutely the way to go.
Our HCC risk coder is out and about in our offices, and she does a lot of education with our physicians, and she's been a huge help since she joined our team.
Wonderful. All right, next question. We only have a few more minutes, so we'll get to as many as we can. Do you see the future of provider scoring being a combination of claims and EHR data together in a singular report?
Absolutely. We're already doing that. We combine our quality information from our EHR with our cost information and benchmarks from Milliman now in order to pay out our PCP incentives on a quarter. Mm-hmm. And I don't know that, I mean, it's a heavy lift, but mm-hmm. It's absolutely worth it.
Yeah, I agree.
Awesome.
I don't know that it could go anywhere else.
Yeah. Okay. Yeah, good answer. All right, next one here is how would you prioritize the different infrastructure components in getting to a solid analytics end state?
That's okay. We have a data architect who actually handles the structure of our data mart. But because we use Milliman, we don't have to give a lot of thought to how our data is built. We have tested it, validated it, tried it over and over again, but it's basically built on a queue where the data is all tied together. What we had to learn to do on our side was make sure that the tables in our warehouse could combine with the tables from Milliman, which took all of our claims data and rolled it up into categories so that it could actually be palatable. And it's not always easy to work with data from an EHR system or from multiple EHR systems, but as often as possible, we rely entirely on claims when we can.
Mm-hmm.
Yes.
And that makes life a little bit easier because it's all Milliman data.
Okay.
I don't know that I addressed the question great, but
it's all right.
So part of, I might chime in here.
Yeah, go ahead. Sure.
amplify some of the points I think, Angie and Sam, that you were just articulating. If you were to thematically prioritize, here's where you might get started if you're earlier on in your journey or your current state isn't as ideal as you would like it to be. One of the most important priorities I'm hearing you describe is a standard approach to ingestion of identifying what your critical data sources are, and then having a data ingestion strategy and a data confidence approach.
Absolutely.
And then hiring the right people with the right skill sets, which was kind of keying off of a previous question here around how do you train those people up and how difficult are they to find, and is there a particular order in which you might recommend hiring those people? And then there's the third component about how do you put that together, which I think you've covered in great detail through the presentation. So I don't know if you have any additional thoughts to that thematically around what your priority recommendations would be, or if there's any insights you might provide in terms of how do you go about building a high-performing analytics team.
I will tell you that it was very hard to do what we did before our data architect had came and cleaned up the data to make it something that was usable. So our data architect is a wizard. I thoroughly believe that she is, because she had taken all of this data and made it clear. And now when we run a query in Milliman, we're not wondering if it's tying out to the right tables, if it's, because Jenny has already cleaned it up before it went that way. So we're very lucky to have her, for sure.
I think on top of everything else, when you take a step back and look at the process of analytics, the first thing you do is you gather your resources. You find out what's available to you, what the timeline is, how old it is, how new it is, how you combine it so you're looking at the same timeline across all data sets. And then you have to have something that receives that data that can make sense of it. And constant validation, constant testing. We couldn't do it. We've said multiple times we couldn't do our job without Milliman. We would not want to do our job without Milliman, because we don't have that kind of time, not with a smaller staff. But we love working with the people we work with. It helps to have passion, curiosity, a desire for impact. I think that analytics are always changing. There's lots of new, pretty shiny tools out there. But the one thing that you have to really look at when you look at something like Milliman, because we probably demoed 10 or 15 tools before we decided on Milliman. For us, it was the fact that it lined the data up in the right way. It may not have had all the standing reports that we knew we needed, but it had all the pieces that we needed to build those standing reports, and in a way that we could quickly automate it and make it accessible to our providers. It helps that you guys have a pulse on the industry and you understand what we're doing on this side.
Well, that is a glowing testimonial and a good way to segue into our closing here. Wanted to thank you all so much for joining us today, this afternoon, as we wrap up. And by the way, if you did ask a question and we didn't get to yours, don't worry, someone will reach out to make sure we get your question answered. We did have a number of those. And we will be sending out a link to the slides and to the recording afterwards. But as we wrap up, I want to encourage you all to head over to bbcexhibithall.com. Check out the Milliman MedInsight virtual exhibit booth that they have there. A lot of great resources. You'll be able to also find this webinar archived along with other ones we've done with them as well in our archive library. And there's a bunch of them there on a variety of topics that may be of interest. So definitely head over to bbcexhibithall.com and check that out. Of course, you can reach out to them through there. And then finally, if you would like to reach directly out to the Milliman team, feel free to do so, and also the Genesys team for that matter. Their information is all on here on this last slide, and of course this will be included as well in the slide deck that you can download later on. Thank you all again so much for joining us today and for a fantastic presentation. Hope you all stay safe and join us on the next one. Bye-bye now.